So I'll pick up where the previous speaker stopped. We have substantial evidence from clinical trials how effective and safe statins, in particular atorvastatin, is. One of the drawbacks of these clinical trials is there is a patient selection. So you have quite well-defined types of patients that are definitely selected to be part of a secondary or primary prevention trial. This one?
Yes.
Yes. Okay. But in clinical practice, we see far more complex patients with multimorbidities, elderly patients that are not always included in these clinical trials. So my role today will be discussing such a multi-morbid patient and what actions in terms of lipids we could do. Now, there's a new term that's cardiorenal metabolic syndrome, because there's a lot of overlap, both in causative factors as well as therapeutic avenues in these type of patients. And the central part is, of course, the metabolic disease, the insulin resistance, diabetes related to cardiovascular progression, atherosclerosis, and kidney disease. And here you can see sort of an overview of factors that play an important role in this new defined syndrome. It's dyslipidemia, it's inflammation, it's genetics, it's lifestyle factors, inflamed adipose tissue, hypertension, obesity, physical activity, diet, and diabetes. And that combination creates havoc, not only in the coronaries, but also in the kidneys, and also, by the way, in the liver and in the brain. Today I will focus on the cardiac and renal part and diabetes part of this syndrome, and realize this is a very, very common feature. Roughly 500 million people are living with diabetes, 64 million with heart failure, 700 with kidney disease, and they are related in terms of risk. So if you have type 2 diabetes, 20% more risk for having heart failure versus no heart failure, higher cardiovascular risk, higher kidney disease, and patients who have heart failure also have, again, a higher risk of chronic kidney disease. So you can see there is an overlapping circle. This is more or less the frame of how it works. You start with, for instance, with problems in the cardiovascular system, low cardiac output, inflammation that has effects on the renal system, that has effect on sodium and water retention, on race. It has effects on anemia, rheumatic toxin, that has effect on the heart again. So this is a perpetuating cycle that goes on and that accelerates disease process, both in atherosclerosis and in renal disease. Now, the traditional cardiovascular risk factors play a very important role in this problem as well, but for the kidney-specific risk factors, there needs to be special attention in the form of biomarker follow-up and maybe sometimes different therapeutic approaches. Now, let's first look at the risk in patients who have impaired renal function. And this is looking at eGFRs over 60 to 60, to 40, to 30, and less than 15. And you can see there is a tremendous increase in cardiovascular complications causing death or morbidities. This is a longitudinal outcome looking at patients for 13 years in an observational way. And what they discovered is that still, even in renal disease, where other factors play a role, best predictors were actually lipids and lipoproteins. Not having diabetes of cardiovascular disease, but having a moderate renal disease problem puts you in a high risk category. And these are some of the features. And here, severe, so less than an eGFR than 30, puts you in the very high risk category for cardiovascular disease. Now, the management, I think, is, again, a combined approach of lifestyle and looking for optimal control of the classical risk factors, blood pressure, and cholesterol, and this is based on the European guidelines. The step 1 for a systolic blood pressure below 140 and LDL below 2.6 and more than 50% reduction. And step 2 for the more increased risk, lower targets for LDL and lower targets for blood pressure. The advice, this is from the KDIGO guidelines for the renal guidelines. There is very hard evidence for statins class 1A to use in patients with chronic kidney disease. For add-on therapies, there is less hard evidence as reflected here, 2A and C. And in patients with dialysis, because there were trials that didn't show a lot of benefit, there is an advice maybe not to start with statins because of the advanced disease doesn't seem to show much benefits. Now, when we talk about patients with renal disease and statins, there's a few important questions that we need to address. And I thought, are they safe is an important question. Do they really reduce risk? Because it's a little bit confusing that in dialysis patients, which are very high-risk patients, there was not a significant benefit. Is there differences between statins? And last, we dive a little bit deeper in dialysis and statins. Now, these are the major trials that looked at patients with renal disease and even advanced renal disease. So 4D and Aurora were the trials conducted in patients with advanced renal disease and even dialysis. And although they didn't show a clear benefit, there was not really an associated harm using statins. Although perhaps in the 4D, there seemed to be a slightly increased risk for ischemic stroke, and in Aurora, a slightly increased risk for hemorrhagic stroke. 4D was done with atorvastatin, and Aurora was done with rosuvastatin. This is looking at a meta-analysis of statin trials depending on your renal disease stage. And you can see that as the renal disease progresses, you have less benefit from the statin. So what we learn from this is we have to start as early as possible. In stage 1, stage 2, stage 3, even stage 4, there is still really interesting benefit, but in stage 4, other factors are more causative in the mortality that we observe. What about eGFR? Is there a negative effect on clearance? Do statins actually harm the nephrons in reducing the removal of toxic substances? And this is a study called the TNT trial. It was already reflected by the previous speaker. These were patients with cardiovascular disease and comparing 80 milligrams versus 10 milligrams. And within that cohort, there were also patients who had impaired renal function. And these were not, of course, advanced, but beginning renal function. And something interesting was observed in this study. If you look over the complete period, there was actually a slight improvement in eGFR, and this improvement was dose dependent. So the higher dosage of atorvastatin showed better improvement of the eGFR than the lower dosage. And that is, I think, is a very interesting add-on features of statins. Not only was renal function better, but of course, major first events by treatment in patients with diabetes and impaired renal function. So in this trial, secondary prevention with renal disease, with diabetes, so typical cardiorenal metabolic syndrome, you can see that statins, and particularly the high dose, high intensity atorvastatin 80 showed improvement. Now we're comparing here, it's a little bit complicated slide. So this is event rate in patients with normal eGFR, that's in blue, and this is event rate in patients who have chronic kidney disease in red. And I'm looking for all these different events. And you can see that particularly in the major coronary artery events or stroke, all improved, but intriguingly, sometimes the patients with impaired renal function even improved better compared to ones with normal renal function. So for atorvastatin, it seems that using this in renal in patients with beginning of renal function and not so much advanced, there is benefit. These were the conclusions from the TNT, that indeed intensive lipid lowering not only reduced your cardiovascular events, but also had some improvement in your renal function. There's another study which was a more or less probe design study called the Greece study, which was conducted in Greece. Patients were randomized to atorvastatin or to usual care. And usual care could be another statin or could be no statin. And this is looking at change in, again, creatinine clearance, no statins, there was a reduction in clearance, usual care, that could be indeed another statin, and intensive care using atorvastatin. And what you observe is a repeat of what we see in TNT. There seems to be improvement with atorvastatin when you look at renal function. This is looking over time in different situations. So this is the start. This is over 48 months. The blue line is no atorvastatin. The red line is no statin. Here you see different statins used, and here you see atorvastatin used. And atorvastatin could be dosaged in 40 to 80 milligrams. So again, this interesting observation of improved outcome. CARD study was conducted in diabetic patients with a low dosage, 10 milligrams of atorvastatin. And again, if we look at patients that were treated with atorvastatin versus who were not treated with atorvastatin, and here there's an extra feature, normal albuminuric and albuminuric. You can see that in the normal albuminuric, atorvastatin did improve. Realize this was 10, this was not 80 milligram, and there seems to be a dosage response. But in the albuminuric, in the placebo group, there was a sharp decrease in eGFR, while the patients on atorvastatin more or less kept a stable level. There is, however, a difference between statins. We have lipophilic, we have hydrophilic statins. And I think the picture for hydrophilic statins is slightly altered. This is the PLANET study looking at patients with proteinuria and impaired renal function and diabetes, and comparing different statins and different dosages. So rosuvastatin 10, 20, 40, atorvastatin 40, and the endpoints were actually renal endpoints. So albuminuria, hematuria, and changes in eGFR. And this is what was observed. Looking at 26 and 52 weeks, rosuvastatin 10 milligram, rosuvastatin 20 to 40, and atorvastatin 40 to 80 milligram. Now, there seems to be no effect of atorvastatin because there is a natural tendency when we get older that your renal function declines roughly by 1 milliliter per year. So this is what you more or less observe between 1 and 2. But in the high dose rosuvastatin, 20 to 40 milligram, there was actually an impaired effect on renal function. This is the global overview. Rosuvastatin 10 seemed to be reasonably safe, but rosuvastatin 40 seemed to have some harms. This is acute renal failure. This is doubling of your creatinine, and this is what we observed in atorvastatin 80. Number of patients is relatively small, 123, 110. Proteinuria did not change in rosuvastatin and actually improved in the patients that used atorvastatin. Now, one interesting feature that I think should be mentioned as well is that when rosuvastatin was registering at the FDA, they also wanted to register 80 milligram. And this was actually not approved simply because there was a clear signal for 80 milligram for proteinuria. So for 10, 20, and 40, that signal was not really statistically significant. And for, as you can see here, for atorvastatin, that seemed to be lower in the higher dosages. And this is what we also observe for simvastatin and also for pravastatin. Now, this is not the only evidence. This is another meta-analysis this is another registry where they looked at patients being treated with rosuvastatin and atorvastatin. Large number of patients, 150,000, 800,000 on atorvastatin. And again, a slight signal that for the patient's renal function, rosuvastatin seemed to be not the best choice. Dose-dependent effect, this is looking at hematuria, proteinuria, and urinary tract infection. There was nothing, but particularly in proteinuria, there was a dose-dependent effect that it increased. Now, what about in dialysis patients? So these were studies, randomized trial, looking at patients with impaired renal function. Alert was renal transplant with fluvastatin, 4D was atorvastatin, Aurora was rosuvastatin, and the Sharp was simvastatin plus ezetimibe. Overall, in the registries, you can see that there is still an improvement in terms of long-term use, and the big debate is, should you initiate statins in patients with dialysis or simply continue statins if they're already using it? Because renal disease is a progressive disease, and eventually, if you continue, you will have, of course, dialysis. And patients on statins seem to do quite well. And patients who were not yet treated with statins didn't have so much harm, but didn't show a lot of benefit as well. There was one group that was slightly different, that were renal patients that suffered an MI, so that suffered an ASCVD event. Those actually improved when treated with statin. Realize, however, that the effect of statins on outcomes compared to the overall effect is only minimal. You know, the risk of cardiovascular disease is high. These are not always atherosclerotic thrombotic events, but these are also arrhythmias and other events causing death. And you can see here, there is only a small impact on that event rate by using statins, but nevertheless, it is something that fits right in, not only for renal disease, but also for the high risk for developing cardiovascular disease. This is looking again at a registry for kidney transplant patients, so a large number of 687 patients, mean follow-up 3.4 years, and particularly in transplant patients, there was also a very nice survival compared to patients who were using low dosage statin or no statins, and these were the patients using high dose, high intensity statin. So in renal transplant, statins, in particular atorvastatin, which is one of the favorite in my armamentarium, seems to be quite good. Third group is heart failure. Now, there were two major heart failure trials that didn't show any benefit. But what was intriguing is that these heart failure trials were all conducted with rosuvastatin. And based on these trials, you can see in this is the Corona study, and this is the GC heart failure study, and there was not real impact of reducing events in those with heart failure. And after these trials were conducted, more or less, heart failure patients would not be indicated in terms of using statins. But over the last few years, we discovered that there are some effects of statins based on their lipid-lowering properties, but also based on their pleiotropic effects that you would expect have some positive impact in heart failure. It has an impact on inflammation, it has an impact on certain cardiac biomarkers, on eNOS, on reducing vasoconstriction. So all the ingredients are there, but the outcome doesn't really show. What they did is they looked at the differences between rosuvastatin and atorvastatin, if that could play a factor. And we do know that lipophilic statins are being taken up much easier in the liver, but particularly also in the heart. And when they did a meta-analysis of 13 trials comparing lipophilic with hydrophilic statins, as you can see, there was a clear benefit. So this was not a randomized controlled clinical trial like Corona and GC. This was like retrospective looking at observational studies with heart failure where patients were treated with either a lipophilic or a hydrophilic. Again, this is the 13 trials, and this is 17 trials with atorvastatin, but not rosuvastatin. This is lipophilic trials, and overall, again, atorvastatin showed benefit that was lacking in rosuvastatin. Here you can see the individual trials. This is atorvastatin positive. These were rosuvastatin. These were atorvastatin. And all these trials did show benefit. So it is intriguing to more or less debate if in heart failure, maybe the rosuvastatin would not be the best choice, but atorvastatin is. Conclusion was, lipophilic statins could be beneficial in heart failure, decrease in all-cause mortality, decrease in cardiovascular mortality, decrease in hospitalization for heart failure, and improved left ventricular ejection fraction. Again, observational, retrospective, so not solid evidence. We actually do need a proper designed randomized controlled trial. Now last, statins and diabetes. Very clear in all patient categories with diabetes, secondary prevention and primary prevention, and looking at different subgroup, all patients shared proved outcome by using a statin. Now, one of the things that we're faced with is that there's a lot of new drugs coming out. And all these drugs are trying to sort of get a piece of the pie of the lipid market. And the biggest lipid market is, of course, covered by statins. So this is a commercial from New Amsterdam Pharma, and it doesn't say anything spectacular, but it does state that statins are associated with a 37% increase in relative risk for diabetes. Now that is bullshit. That is really bullshit. This is pure marketing to say, yeah, but we have now a new drug that will not give you diabetes. Now I hope I can convince you today that statins and diabetes is a completely different story. First of all, the really hard evidence is from the CTT meta-analysis, Cholesterol Treatment Trialist Group. They have all the data from all randomized controlled clinical trials, and they are able to really drill down and see what the harms and benefits are. And you can see here, there was a slight increase in HbA1c, a small upward shift in glycemia. Is that clinically relevant? To a certain extent, but realize it's not just statins that give you diabetes, it's this what gives you diabetes. It's your lifestyle that is fueling diabetes. And this was actually a study that showed if you drink one sugar or artificial sweetened drink per day, that is associated with already a 38 or 23% increase in your risk of developing diabetes. Now, what are we talking about with statins? Let me show you. This is data from the TNT trial. I think we have used this quite extensively today. If you do not have a risk factor for diabetes, and that's metabolic syndrome, so obesity, hypertension, hypertriglyceridemia, if you don't have them, the patients who were treated with 80 milligrams of atorvastatin actually seem to be slightly lower in their risk for developing diabetes. But if you had 2 or 4 of these risk factors, yes, your risk for diabetes increased significantly. However, if you now look at the real grain of why we're doing things, this is major coronary events. These were the ones with 1 or 2 risk factors, and these were the ones with 2 to 4 risk factors. In other words, the ones at higher risk of developing diabetes actually had the most benefit of using a statin to reduce that risk. And that's what it's all about. Now, you think you're harming your patient if you give a statin and it might kick him over the edge with developing diabetes. No, you harm your patient if you don't give a statin and protect him from lethal events. The real culprit in diabetes is not the statin, it's the patient. You have to have a patient that realizes that and then does something in lifestyle, exercise to reduce that risk. Finally, the first trial that showed us that statins were pro-diabetogenic was the Jupiter trial, using rosuvastatin in patients with more or less metabolic syndrome. What it states here in the conclusion, by comparison with placebo, statins accelerated the average time to diagnosis of diabetes by 5.4 weeks. Now let that sink in. The patients in the placebo group also developed diabetes, but 5 weeks later. So what are we talking about with statins and diabetes? It is a real non-issue. What is the issue? Preventing atherosclerotic disease, and that's what they do best. To conclude, atherothrombotic disease is the real culprit when we talk about cardio-renal metabolic diseases, and they share a lot of risk factors that we're very aware of. Lipids, hypertension, and also glycemic control plays an important role, and we have some really interesting drugs like finerenone, like the new GLP-1 or the SGLT2 drugs that could be perfectly tailored for these kind of patients. Now we have a little bit more evidence that shows atorvastatin actually benefits in those patients, and in end-stage renal disease, based on the clinical trial evidence, yeah, it's safe to continue, but it's sort of, you can discuss if it's really interesting to start. And last but not least, atorvastatin is associated with improved outcome in heart failure. This is not hard, solid evidence. It will not be part of the guidelines, but it's an interesting thought. And statins remain indispensable in reducing risk in type 2 diabetic patients. And that was my last slide. Yes. Thank you very much.